Good day, everyone, and welcome to today's webinar, State Policies to Strengthen the Direct Care Workforce. Before we get started, we'd like to review a few technical items just to make sure that you can interact with us today. Q&A. Please click your Q&A button and a window will appear where you can submit a question, and we'll try to take as many questions at the end as possible. We are recording today's session. However, your line is muted, so you don't need to worry about the recording capturing your interactions. And we will provide access to the recording on NASHP's website for you to view and to share the recording as well as the slides after today's event. So I want to thank you all for joining us. If we can have the next slide, please. And here I am. My name is Wendy Fox-Grage, and I'm a project director here at NASHP. And I want to thank the John A. Hartford Foundation and the RRF Foundation for Aging for their generous support of today's webinar and NASHP's RAISE Family Caregiver Resource and Dissemination Center. I specifically want to call out a big thank you to Ronnie Snyder, Scott Bain, and Nancy Zweiwalt, who are fantastic project officers. On our agenda today, we've got a great lineup of speakers. We're going to start with Robert Espinoza. He is the Vice President of Policy at PHI, and he's going to talk to us about state solutions to strengthen the direct care workforce. Next, we're going to have presentations from Bill Kennard at the Arizona Healthcare Cost Containment System. And then following up, we'll have Dr. Haley Gleason at the Colorado Office of Community Living. And they're going to talk about policies within their states to strengthen the direct care workforce. And then we'll go into Q&A. With that, thank you for joining us. And I'm happy to say, Robert, please take it away.
Thank you, Wendy, and good day, everyone. It's a pleasure to be here. I do want to start by thanking Wendy and the National Academy for State Health Policy and all of my fellow presenters for this conversation today. It is a critical issue that many states, if not all states, are facing, and I look forward to the conversation that's taking place. Next slide, please. For those of you who aren't familiar with me, I work for PHI. I'm the Vice President of Policy. PHI is a national organization that's focused on strengthening the direct care workforce, and we do that through three mechanisms. We study the workforce and produce data and research and analyses on the policies that shape their lives and their jobs. We also advocate for policy reform at the federal, state, and local level, and we design a range of workforce interventions related to direct care workers in the areas of training, recruitment and retention, advancement opportunities, and so much more. The information that I'm sharing today is from that 360-degree perspective on long-term care. We really try to take into consideration the needs of workers, of employers, of consumers, and of other stakeholders in the long-term care sector. Next slide, please. Our research shows that there are about 4.6 million direct care workers in the US. The typical direct care worker is a woman. She is in her 40s. She is typically a woman of color. Also, about 60% of direct care workers are people of color. About 25% are immigrants. 1 in 4 is aged 55 and older. So in many cases, we're talking about workers, older workers supporting older people. And about 1 in 4 direct care workers has a child under the age of 18, as we think about the range of parent and family supports that many workers need. Unfortunately, because wages are poverty level for these workers, about 45% live in or near poverty. Many of them work part-time and are relegated to part-time work either by their employer or by the economy. It's also clear through our research and through surveys that many direct care workers value the work that they do, but they are likely not to stay in the job. In fact, turnover rates hover between 40 to 60% at a minimum, and often within the first 90 days. Next slide, please. Because of high turnover rates and the growing demand for direct care workers, we estimate that the long-term care sector will need to fill about 7.4 million jobs in direct care between 2019 and 2029. And it's a formidable challenge that I think has been amplified by the COVID-19 crisis that many people at the state and local level and at the national level are witnessing and are seeking solutions for. So I'm looking forward to this conversation today. Next slide, please. I just want to share this quote by Erica Honan, who is a home care provider and an emergency response team provider in San Francisco, California. She says, quote, "I think isolation in general is a challenge for caregivers, but with the risk of COVID added, it has really been very taxing. I'd say that's the hardest part of the job for me." And I included this quote, one, because I think it's important for us to always hear from workers themselves, but also because it speaks to the ways in which this pandemic has amplified long-standing challenges facing these workers. In fact, one of the challenges that often goes unnoticed is the emotional role that workers play and the challenges that they've been having in this pandemic, the need for bereavement support and grief support, among other mental health supports. So it's an important quote to consider. Next slide, please. The ideas I'm going to be sharing from my remarks this morning come from the framework that we established early last year through our signature report called Caring for the Future. For those of you who haven't read it and are interested in a primer on the direct care workforce, I would highly recommend it. It's available on our website at phinational.org. It's a report that covers the wide range of issues and realities facing the direct care workforce and what it would mean to truly transform this job to be more successful in their delivery of services and supports, but also to strengthen the long-term care sector. We also offer a framework for policy and practice recommendations that covers 8 areas. And I'll be describing state approaches that align with those 8 areas as my remarks, though of course I'll keep it brief for time purposes. Next slide, please. Next slide, please. So the first area that we cover in the report is the importance of reforming long-term care financing. What we're seeing here in this area is the importance of creating perhaps a better and alternative financing approach for direct care jobs in long-term care. Medicaid is the primary public payer, as many of you know, of long-term care in this country. And because of that, it is the primary public payer of direct care jobs, especially in the Medicaid-funded market. What we're seeing states do, for the most part, in ways that I think could be transformational, is exploring the importance and the value of state-based social insurance programs in long-term care. A highlight in this regard is Washington State, which has established a state-based long-term care social insurance program that really, I think, models for the country what it can do in terms of making long-term care more affordable for people who need it and who aren't necessarily in poverty, but also it's designed in such a way that it could be used to improve the quality of direct care jobs. But it's really critical that whenever we think about direct care jobs and improving them, we think about the financing system behind it. Next slide, please. A second area, and this is often one of the most visible areas of support for direct care workers, is the importance of increasing compensation for direct care workers. There are many models that have been implemented around the country. We've seen, for example, in New York, a wage parity model where home care workers are offered a higher wage that is typically aligned with cost of living in certain parts of the state. And it offers them an opportunity to make more and to really stay in these jobs and address kind of the turnover rates in this country, in this sector. So we are seeing efforts like that around the country. We see states looking at establishing wage floors for either direct care workers or for low wage workers in general. Some localities and states have also adopted minimum wage laws, though we encourage that those laws consider the ways in which the long-term care sector should be better financed so that some providers don't end up cutting service hours as they meet those minimum wage requirements. Next slide, please. The third area is about strengthening training standards and delivery systems for direct care workers. And here we would use an example from Washington State as a highlight. Next slide, please. Since 2011, Washington State has required all agency employed and consumer-directed personal care aides to complete about 75 hours of training. And they use a state-sponsored or state-approved curriculum. They pass a competency exam, and they complete 12 hours of continuing education per year. There are other details. We actually have a case study on our website that covers that, but this is a great model for how you can really improve the training infrastructure and the training approach for personal care aides and consumer-directed models in particular. Next slide, please. The third area is about funding, implementing, and evaluating direct care workforce interventions. These are the range of interventions that can really strengthen the job, from training approaches to advancement interventions to recruitment and retention efforts. Next slide, please. In Arizona, a managed care company called Mercy Care established a $1 million innovation fund that enables providers to test new recruitment and retention strategies. Of course, we think the best way to improve recruitment and retention is to improve the overall quality of the job, but there are immediate interventions that should be understood and replicated. This is an example at the provider level or at the managed care level, but it's also something that a state can do. They can establish an innovation fund that would allow the field to devise the kind of strategies that should be implemented, and we would highly encourage that. Next slide, please. Another area is in regards to, next slide. Oh, I'm sorry, this is the next slide. This is another example from Minnesota, which provides a direct support connect registry that is available to consumers who pay for services out of pocket. Many other states have developed matching service registries that pair consumers who need home care workers with available workers based on their preferences, their needs, and availability. Unfortunately, the number of matching service registries in this country has decreased over the years instead of increasing, so we would highly encourage states to develop those models. Next slide, please. Of course, it's important to improve data collection, specifically to monitor and better understand this workforce. Next slide, please. In Texas, since 2018, they have required all long-term care providers to submit data on the size, stability, and compensation of their employers. This allows the state to track and measure the workforce, but also to better understand specific interventions that certain parts of the state might need more than others. This was especially important during COVID-19, where certain regions became hotspots within states, but most states don't have that data to really implement the approach at that level. Next slide, please. Another area is, of course, rectifying structural gender, racial, and other inequities. Next slide, please. This is specifically about looking at disparities within the direct care workforce that women, immigrants, or people of color might be facing. Also thinking about the ways in which states can center direct care workers themselves. Are there advisory committees? Are there other commissions that have been established where workers can offer that guidance themselves? Next slide, please. And of course, the importance of shifting the public narrative on direct care workers. Too many people, unfortunately, still wrongly assume that direct care work is low-skilled or unskilled work, and there isn't enough awareness about these challenges that I've described in today's presentations. Here, states can adopt and fund public education approaches that really educate people on these challenges, but also recruitment approaches that might recruit workers into this sector. Next slide, please. In Wisconsin, as part of their Caregivers career program, they funded a recruitment public education program where they interviewed nursing assistants in Wisconsin to describe both the intrinsic and the extrinsic benefits of their jobs. And then they used those videos to recruit more workers into this program with much success. They've had thousands of workers apply to their Caregivers career program. And this is certainly a model that other states can embody. It can also implement. Next slide, please. Just before I close, I do want to say that sometimes that work is more intensive at the state level. And at PHI, we do have a workforce research and strategy program where we have partnered with states on specific measures that are more intensive, either over the course of 6 months or over the course of a few years. So certainly we're open to those conversations. Next slide, please. Also, all of the information, the final thing I'll say is that we do have an initiative in 3 states where we've been working for a few years to work with coalitions and state leaders to advance many of these measures. And we would encourage people to attend some of these virtual trainings that are coming up, and we can make information available. Next slide. Also, all of what I've shared is available on our website at phinational.org. And I encourage people to, of course, visit our site and download any information that might help their state. With that, thank you again, and I look forward to hearing my co-presenters.
Thank you so much, Robert. We so appreciate that. And with that, let's go to Bill. Bill, take it away.
Well, thank you, Wendy, and Robert, thank you for such a really wonderful and descriptive description of what's going on across the country. So my name is Bill Kennard. I'm the Healthcare Workforce Development Administrator for ACCESS, the Arizona Medicaid Agency. And it's really a privilege to present our approach to you today. In thinking about this, my presentation, I was thinking that most of us are dealing with the same challenges, and many of us have come up with a lot of very similar solutions. And so I was trying to figure out from Arizona's perspective, what's kind of maybe unique or what's interesting about us that might be helpful to the rest of you. And I think one of the things that we really are committed to, in addition to kind of doing all of the things that really Robert has really tried to outline that should be done, is to create a system for doing it. So we really are trying to create a workforce development system. And that's what I'm going to describe to you today, kind of what the policy basis for that is, how we engage our partners in a shared vision and create a common really set of processes for doing that, for doing workforce development across our healthcare system. Before I do that, though, I'd just kind of like to give you a little bit of an overview of the ACCESS system. So next slide, please. So Arizona is a primarily managed care state. We operate under an 1115 waiver. We're the largest insurer in the state. We cover roughly 2 million lives. We have approximately 114,000 plus healthcare providers, and we contract with 15 different managed care entities. 7 managed care entities are responsible for the networks around integrated physical and behavioral health care. 4 are in the long-term care space, 3 working with the elderly and physical and developmental disabilities. The others really are sort of around behavioral health, foster kids, and and that would be it, actually. That would add up to 15. Our workforce, our long-term care workforce, is kind of really, Robert described it very well. I'd say the only 2 differences are, one, that our workforce actually is, the majority of those workers are actually working 2 jobs or 3. So, the wages are really, are concerned on a day-to-day basis for our workforce. And, the other part of our workforce that sometimes people find it very interesting is that around our attendant care workforce, approximately 50% of those workers are actually paid family caregivers. So we're at once really proud of that, but also terrified about that because, in our workforce shortage right now, should a family member go down without another person to step into that, it just kind of exacerbates a very difficult situation. But that's kind of our challenge right now. And if I could, the next slide, please. So there are 3 policies that really kind of undergird our approach, our system approach here. One is AMPM 1240, which describes our HCBS services. And we have a pretty broad and extensive approach to providing HCBS services, including our behavioral health, as well as our the long-term attendant care and in-home care supports. ACOM 429, that I'll spend a little more time on, is really takes care of that area that Robert was really talking about, a kind of a systematic training approach for direct care workers. And we find that that's something that's very important, not only to the workers, but also to the satisfaction of our members. And last but not least, the ACOM 407, which is our workforce development policy. And that policy requires all of those 15 MCOs to have a workforce development operation. And I'll describe what that operation means. And that's those things are really those operations from that from those MCOs. That's really what is going to be the backbone of our system. And again, our system is really designed to not only help us kind of deal with the challenges that we find today, that we're dealing with today, but also to help us execute the solutions into the future and hopefully be in a better position should we ever face these challenges ever again. The next slide, please. So our DCW training and testing program kind of consists of really sort of the fundamental requirement that all DCWs must complete a standardized testing and training program. So just when you come in the door, you have to complete that, and you have roughly 90 days to actually do that, but that's an essential requirement for employment. There are specific training and testing agencies. We evaluate them, they apply, we approve them, and those testing and training agencies can be independent organizations that are in it specifically as training entities. They can also be provider organizations who also organize and have an approved training component, but they really do have to be, we view them as a separate element of that organization. And then there's also community colleges and most recently high school programs that are offering DCW training programs. So an exciting development actually over the past 3 years. Almost 27 high schools now across the state have DCW training programs. The training that's offered by the training and testing agencies must use or be based on the principles of caregiving. And the principles of caregiving was a joint access and industry endeavor a few years ago to define the basic competencies that we want DCWs to be skilled in, and not only the mechanics, but also the interpersonal elements of caregiving, as well as a kind of a model, if you will, curriculum or way to teach that competency-based training. Training providers do not have to use that curriculum, but they must base it upon that curriculum and certainly those competencies. In addition to kind of the principles of caregiving, there's a second level, which kind of is more specialized around providing services for individuals with intellectual and developmental disabilities, as well as individuals who are receiving support due to age or physical disability. We audit quite a bit for the training, the trainer's expertise and experience. We don't want just somebody who took a course to be a trainer. We want them to have a couple of years experience as a DCW and have good experience with that, as well as skills as a trainer. Training agencies must use the standardized tests. Access has developed those tests, and we basically rotate those tests to the training agencies to use. Challenge testing is allowed. So we don't believe that people should just be trained even though they already know something or are good at something. So an individual with experience can request a challenge test, and should they pass it, they wouldn't necessarily have to participate in the full training program. We also have a database that once an individual completes their training and they're now they have a certificate as a DCW, they're entered into that database. Providers can actually use it as a source of who can I recruit, but also an individual who is, let's say, goes inactive for a couple of years, we can find that we mark them in an inactive status, and then if they decide to rejoin the field, then they may have to retest or retrain if they've been inactive for a couple of years or more. We've recently expanded kind of reciprocity with between our direct care or in-home care providers and also our assisted living caregiver program that was administered by a separate board of nursing agency. So essentially, if you've gone through the DCW training and competencies, then you're eligible to work in an assisted living facility and vice versa. The last element of 429 is really required auditing by the MCOs, and just to make sure that the content is fresh, the other standards that are required to be a training and testing agency are being observed. So next slide, please. ACOM 407 is a kind of a recent development over the past 3 years. Well, actually, I guess it's 4 now. We require all workforce development, all MCOs to have a workforce development operation. And when we say that, we basically really are trying to describe this system that we're trying to put into place. So we really are describing kind of the role and purpose of workforce development in the state of Arizona. So what's our philosophical base? We use a thing called, the 5 C's, and the functions of that workforce development operation, that we want workforce development not to be a silo within a managed care organization, but to be highly integrated with its quality management and its network management and other functions as well, cultural competency for an example. But we want those, and we want to understand how those organizations are working together to really understand what's going on in each of those workforces, and actually to figure out, what are the solutions. We have a common approach to workforce assessment and planning. We require our MCOs to have a workforce development plan for their workforces, that they have networks that they manage, and to update that every year. We require ongoing workforce monitoring, of course, data collection, and then providing technical assistance to providers in workforce development matters. As you know, probably in most states, you have some providers who are highly sophisticated and complex workforce development operations of their own. And then you have others that really struggle with that. So what we want is our workforce development teams in the MCOs, not to just kind of observe and understand, but really to understand, to engage, understand, and to act proactively with the providers to help them around their workforce development challenges. Next slide, please. One of the sort of things that people say, oh, how do you guys get that to happen? And I have to confess that Access really didn't make this happen. Actually, the MCOs kind of created the need for themselves and a solution for doing this. But we just put it into policy, and the MCOs must collaborate as a workforce development alliance. So in addition to managing the workforce issues, monitoring and assessing and planning for their particular networks, we meet regularly, monthly, but also just as formally annually to do kind of a state of the art of the particular workforce and its challenge and the proposed solutions. And these solutions actually would be things that would benefit the entire workforce, let's say long-term care, the example I've on the slide. So we're really looking at these be solutions or initiatives that those 4 managed care organizations who are working with direct care workers in this particular case would commit to working together towards improving the situation with those workers. And right now, of course, and when we think about our 5 C's, workplace connectivity, workforce capacity, capability, culture, and commitment, we are really focused around direct care workers right now, really challenged with the whole idea of just ensuring capacity. So next slide, please. We also make extensive use of advisory councils. So every workforce and every MCO kind of alliance has an advisory council. And those advisory councils are really consisting of provider associations, so kind of our main industry groups, members from the provider organizations, as well as our external partners, colleges, universities, community colleges, high school, as well as technical expertise from the outside, in other areas of workforce development as well. We find that engagement and long-term kind of strategies around understanding the workforce and really sort of helping us shape solutions on a statewide basis is very, very helpful and useful, particularly as we've gone into ARPA. And the last slide there, please. Kind of what we are trying to execute right now and to use our system to do is to build this sustainable approach to workforce development. And I won't go into all of the various initiatives, but I think, we tried to follow PHI's lead in this in many areas, but certainly we're trying to build and use ARPA funds particularly to build that awareness campaign that really not only shows the value and the challenge that of the life of a direct care worker, but also kind of the opportunities for individuals to enter into the field or to rejoin the field, to become direct care workers, and the kind of the satisfaction that direct care workers are very happy to share with them. So we're putting some effort into creating that. Creating a career development opportunities, both as kind of attracting students particularly into the field and showing them their career paths through, by starting their careers as direct care workers, but also attending to the direct care workers who are currently working there, that looking at, some of them had college aspirations or certification aspirations, and how can we enhance that as well. We want to enhance the training opportunities. A recent survey actually that was conducted in Arizona identified that most DCWs are really happy with their initial training. However, there was a lack of in-service training, and that lack of in-service training was a key contributor to dissatisfaction and thinking about leaving the field. So it's an easy lift to really sort of figure out what those training programs are and what would be helpful. It's a little harder to figure out the best way to make those programs accessible and relevant to people. But that's kind of one of our other major initiatives right now. We want to assist our provider networks in workforce development planning, of course, incentivizing recruitment and retention, and building a more robust data and metrics and analytics system. So thank you very much for letting me address you this morning, and this morning here in Arizona anyway. And I look forward to your questions. Thank you.
Great. Thank you so much, Bill. We so appreciate that. And so now what we're going to do is we're going to move from Arizona and we're going to go to Colorado. So with that, I'd love to introduce you all to Dr. Haley Gleason. Haley, take it away.
Thank you so much, Wendy, and thank you, Robert and Bill. Those were great presentations, tough to follow. As Wendy said, my name is Dr. Haley Gleason. I'm the Strategic Outcomes Division Director and Economic Recovery Officer within the Department of Healthcare Policy and Financing in Colorado. We are the state Medicaid agency. Next slide. I'm thrilled to be able to talk to you today about some of our direct care workforce strategies. As both Robert and Bill have shared, the challenges facing the direct care workforce are complex, and there's really no silver bullet solution. So Colorado has taken several steps to move us towards action. First, a commitment was made to take a holistic approach and tackle the issues head on instead of working around the edges. So to begin, we needed to understand the totality of the challenges facing this workforce. So we began by really defining the problem. Second, we needed to identify and work towards solutions, which really required varied expertise, and thus a cross-state agency coalition was brought together. Third, we needed to develop the goals and really launch our short and long-term action steps to accomplish those goals. And finally, we needed to build a strong, diverse stakeholder partnership to help move that work forward. So I am going to talk you through all of those steps. Next slide, please. So first I'm just going to start by explaining a little bit about our cross-state agency work group. So my department, which we refer to as HICPUF, serves as the convener for the group. And we assist with meeting planning and facilitation, but the group is actually made up of seven different state agencies, and including representation from the governor and lieutenant governor's office. The group was formed back in 2018 at the request of the health cabinet, which is led by our lieutenant governor. And really, this group was tasked with defining the problem, outlining goals, and developing an action plan to address the direct care workforce crisis and stabilize the workforce and really move towards long-term solutions. How we've done that is by creating multiple 2-year action plans, which were approved by the health cabinet, and we reported back on, or we continue to report back on a biannual basis, which added some accountability to that process. Next slide, please. So this group helped form our goals at a statewide level to say, what is it that we're really hoping to achieve in stabilizing the workforce? And you'll likely see some overlap here between what Bill talked about as well as Robert. First and foremost, our last action plan was launched this last summer in 2021. So obviously supporting crisis response and recovery was front of mind. Second, we really felt it was important to continue to expand on our cross-agency collaboration, realizing that no state agency, honestly, no individual or stakeholder group can solve this problem themselves. So we really needed that cross-state collaboration. Third, we really needed to recruit new individuals into the field. Our current recruitment strategies were not working to effectively have enough workers to meet the current or future demand. Fourth, we needed to build out career ladders and growth opportunities. Individuals, in order to recruit individuals into the field, they really needed to see that there was stepping stones for them to continue to advance into other allied health professional fields. 5, we needed to improve retention. I think Robert mentioned that the turnover rate for this workforce is extremely high, and we really needed to keep those workers who were already in the field. And 6, we needed to develop a strong stakeholder alliance to help us to move the strategies forward. Next slide, please. So those were our goals, and these were the strategies that we created to align with those. First, in order to provide that immediate relief to employers to address the impacts of COVID-19, we needed to look at short-term or temporary rate increases for the providers to be able to, offer hiring bonuses or hero pay, or to pay for the high cost of bringing in as those staffing agencies to help. We also wanted to continue to offer direct hands-on assistance. Second, we needed to continue to build out our cross-agency collaboration. And in particular, ARPA gave us a great opportunity to look at stimulus funding that was coming to various state agencies and figure out how we could leverage that to support the direct care workforce. 3, we needed to raise awareness about direct care positions in order to recruit new individuals into the field. A lot of people don't know about these positions, and so we needed to make sure that the value of this work was really understood. 4, we need to create career advancement opportunities by redefining the direct care workforce position credentials and removing barriers to advancement. In Colorado, we have something like 15 different definitions in our rules for direct care workers across the different state agencies. And not only is that confusing for people who are trying to get in the field, but it also limits the opportunity for people to advance because they have different training depending on where they're working. So we really wanted to look at that. And we also needed to look at how people could more easily advance out of these positions if that's what they were looking to do. 5, we needed to promote retention through known best practices and improving overall compensation for these workers. And 6, we really needed to activate our industry stakeholders to refine and accelerate other efforts. So we needed the help of a very diverse stakeholder group in order to be successful in moving the work forward. Next slide, please. So as many of you are aware, we had this incredible once-in-a-lifetime opportunity through ARPA, particularly Section 9817, focused on home and community-based services, to actually supercharge some of this work. And so Colorado anticipates funding of approximately $530 million. Our spending plan was approved by CMS and the Colorado Joint Budget Committee back in September, and we have 65 initiatives included in our spending plan, and over 50% of our total budget, that $530 million, we have dedicated to the direct care workforce. So we made this our top priority, and have really made the commitment through our funding to address the challenges and to put some of these strategies into action. Next slide, please. This is a high-level overview of our projects that are particularly focused on the direct care workforce. I am going to actually go into a little bit more detail on the next slide, but wanted to give you a snapshot of the funding and how we split that up across the projects. Next slide. So because we had started this work well before ARPA came into existence, we had a really wonderful roadmap when the opportunity came about. So we were able to go straight to our goals and strategies and say, what is it that we need to do in order to move this work forward? And so you can see that all of our actions really do align directly to the goals and strategies. So again, around COVID response, we knew that we needed to get funding out very quickly to our providers in order to address the workforce shortages and crisis they were experiencing right now. So we implemented a 2.11% rate increase retroactive to April 1st, 2021 in order to do that. We also have continued to offer direct hands-on assistance to those providers that are in crisis through the National Guard and through medical staffing contracts. Second, we have continued to push forward that cross-agency collaboration. For instance, one of our projects includes a partnership between the community college system, higher ed, and the Department of Labor and Employment in order to really map out and develop those career pathways for direct care workers. Third, we are launching a public awareness campaign as well as building a new website which we're calling the Resource and Job Hub, where individuals interested in pursuing these jobs can go and learn more, can access training, and can also look for jobs. Number 4, we are building career advancement opportunities. Where we're beginning is actually developing a core standardized curriculum, sort of moving towards a universal worker model to get away from this challenge of having so many different types of direct care workers depending on the population and setting. So we are developing that curriculum as well as adding specialization modules for particular populations and needs. And then we're also building those pathways. We, as of January 1st, implemented a new $15 per hour base wage requirement for all HCBS workers to address some of our challenges related to wages. And finally, we are continuing to leverage a group we call the Direct Care Workforce Collaborative as our partner in executing all of these initiatives. Next slide, please. We believe stakeholder engagement and partnership is critical to achieving our goals. So we launched our stakeholder engagement efforts back in fall of 2020 as a kickoff. And we hosted a Direct Care Workforce Summit. It was a statewide effort. And then following that, launched our Direct Care Workforce Collaborative in January 2021. This group is stakeholder-led, though HICPF serves as the backbone organization to support the group. Next slide. Here's a little bit more about the collaborative structure because we were really intentional when we designed this. Again, we really felt strongly it needed to be a stakeholder-led initiative. It is intended to be a diverse group of stakeholders, individuals, direct care workers themselves, care recipients, family members, advocates, and providers all sitting at the table to develop and move forward actions to address the workforce crisis. Again, just a little bit about the group. The collaborative overall meets on a quarterly basis, and we have 2 co-chairs that lead the collaborative, who are, again, stakeholders from the community. And we have action groups, which are focused on particular topics that were identified by the collaborative, by the stakeholder group, for what they wanted to focus on. Next slide. I've included a couple of links in case you want to learn more about either our American Rescue Plan Act strategies and projects or the Direct Care Workforce Collaborative. Thank you so much.
Great. Thank you so much to our presenters. That was fantastic. And we have amazing questions. We have over 20 questions, and we're just going to try to get to them as many as we can. So, Robert, this first one is for you. We've gotten a couple of questions about direct care worker registries. How can they get more information? And then are the registries matched to private pay care seekers? And why is this kind of decreasing over time instead of increasing? As you had said, we're seeing less instead of more.
Yeah, those are great questions. I also included a link to a resource on our website where you can see all the existing matching service registries and get more detail on them. The response to part of this question, I think, is reflective of the direct care workforce in general, which is that registries vary by state and they vary by quality, right? And so when you look at the national landscape of matching service registries, some states will have very evolved models that have smart technology platforms that integrate both consumer-directed workers and sometimes go a little bit beyond that. But in many cases, they were developed, I think, with insufficient resources to embody the kind of technology and user-centeredness that typically a registry should have. So I do think part of the reason that this sector has decreased over time, and we're not seeing as many states with matching service registries, is that it is a significant upfront investment and it requires a good amount of technology know-how. And it should also be a partnership between kind of the long-term care leadership and the technology world and leadership that can really bring those best practices. Otherwise, they really become just websites that house some useful information, but they're not as tech savvy or as friendly as they should be. I hope that this trend reverses, because really every state should have a matching service registries where both the consumer can find a worker, but also the worker can find a consumer that matches their needs, right? It's really, I think, the trend for the future. Yep.
Great. Thank you, Robert. Bill, these next questions come to you, and we've gotten a lot of interest around your direct care worker training programs, especially for high school students. Can you talk a little bit about, are they integrated into the public school system? How do you kind of get the information out about those? Are they in rural areas, and who's organizing those programs for you?
Sure, Kennard. Great question. So the Department of Education actually is the organizing entity for this, and they're in the public high school system, particularly within the section of what we call the career education and career and technical education programs. So that's kind of where they're housed. It's called the Home Health Aid Program. You wouldn't see direct care worker, and my understanding is that's just part of kind of the part of a federal requirement that sort of limits the names that they can use for the program. But essentially, what the program is a direct care worker training, so that we audit those programs, approve them, do everything that we would ordinarily do with a private provider or an independent training agency. The programs actually, interestingly enough, were initially generated in very rural areas, particularly in the northern areas and some of our tribal high schools in the tribal areas. And they've kind of grown into Maricopa County, which is kind of the area around Phoenix, and then most recently into the Tucson and Flagstaff areas. So they were kind of an economic-based workforce development initiative in the rural areas, just because there were so many people who were being caregivers for their family members. And then there were, sort of the emergence of a lot of the in-home caregiving companies there. And it's just kind of grown. So we're actually, with 27 programs, I mean, we're really hoping, this year and next to graduate, somewhere on the vicinity of 600 to 800 students who would then, go on to be direct care workers.
Great. Thank you, Bill. Haley, this next question is for you. Do you know what the base rate is in Colorado for direct care worker salaries? And then also, you talked about the process of developing workforce goals and strategies and actions, and just wondering if direct care workers were a part of that process.
Yeah, thanks, Wendy. So using BLS data, we know that the mean wage for, at least for home health and personal care aides, is about $13.83 an hour in Colorado, though I think, as Robert mentioned, the data available for this workforce is quite challenging. And so it is one of our projects in ARPA to collect some additional data to be able to better speak to the current situation for our workforce across the state. And in terms of developing strategies, so both as part of our Direct Care Workforce Summit and integrated into our Direct Care Workforce Collaborative are direct care workers themselves. So obviously we want them and their voices to be at the heart of our process and of our thinking through the actions that need to happen in order to improve their current work. So we have made every effort to try to engage them and continue to do so. We're for this next year for the collaborative are thinking through some additional ways, such as having some kind of off-hour meetings, offering opportunities to submit ideas, through surveys or through some other forms if they can't participate in meetings live, potentially like having weekend opportunities to engage. So really trying to be creative about how we can outreach and make opportunities available to everyone, even those who, are working during the day and may not be able to participate in sort of a meeting that may be held. So continue to look for new ways to do that. But yes, have really tried to hear their voices as we have developed these strategies.
Great, thanks. This next question is to any of you that want to answer this, and it's around self-direction programs. And do these direct care worker trainings, do they pertain to workers and sometimes their family members, quite honestly, who are providing the care within self-direction programs?
So we are just at the kind of precipice of developing our training, but I can say at this point for our consumer-directed program, we are not including them initially. We are developing it more for our traditional sort of agency or institutional setting-based workers. But I will say that we are, in our design of the training, are making it free of charge and available and modular so that anyone that may be interested in going and accessing the training, whether it is a consumer-directed worker or maybe even a family member who wants some training, they would be able to access it. So at this point, it wouldn't be something that we are requiring or extending to that workforce. Not to say that wouldn't be in the future, but really want to make sure that that is an option if they want to access it.
Arizona's approach is similar. Even if you're a family member, some of the dedicated worker, you're employed by an agency. So essentially, Access does not contract directly with caregivers. The Division of Developmental Disabilities, I understand, is as part of their oversight of the intellectual and developmental disabilities networks, has some provision for that. But basically, kind of as Haley said, our requirements are primarily for those direct care workers who are actually providing services to many or non-family members. But in the same kind of vein, we are trying to make that direct care worker training attractive to individuals, and actually many individuals do choose to participate in all or a part of it. So we're spread, but it's not required for family members who provide care.
Okay, thank you. And then all of you mentioned awareness campaigns to increase recruitment. Can any of you speak to the results that you've had or have seen with the recruitment campaigns, since it is so difficult, especially now with the worker shortages?
I cannot, maybe give Haley a couple of minutes here to think about it, but we're actually just at the beginnings, kind of where we are. We've realized our approval from CMS, and we're kind of working the process through our legislature to get final spending authority from our legislature to actually, to begin allocating our ARPA funds. So we haven't actually started that, but our awareness campaign. So
we're right there with you, Bill. It is on our list. We are moving forward with sort of identifying contractors to help us launch that, but we have not done it yet. So we'll be excited to report out once we have some evaluation data on it.
If I can answer that question, a few years ago, I interviewed a senior living provider in Minnesota, in rural Minnesota, I feel like that's a theme today, about their recruitment campaign over social media. And I included a link to that interview in the chat. They basically partnered with a marketing firm in Minnesota that specializes, among other issue areas, in long-term care and in recruitment and retention approaches. And they developed a really interesting model, and it's included there in that diagram, in that link that I sent, where they show what the recruitment cycle typically includes, and then created a social media campaign tied to each element of that recruitment cycle. And what it led to was dramatically improved recruitment and hiring figures. So I think between 2016 and 2017, the number of new applicants increased by 33%, the number of hires increased by 46%, and the number of vacant positions decreased by 45%, and retention didn't necessarily go down. So the quality of candidates was still at least a similar level. So that's a great example. Yep.
That is fantastic. We are in the final moments of the webinar, and I just wanted to give each of you like a quick 1 minute of kind of big lessons learned from your work in this area. And going forward, any last comments? Robert, we'll start with you.
Sure. My quick comment, and it was referenced in a few comments in the chat, is just the importance of ensuring that workers and older adults and people with disabilities are included in the design and in the testing of any of these interventions from the onset, because I do think that their insights are so critical to the success. But thank you.
Great. Bill, last comment, parting words?
I wish I could have said it better, but engagement of not only members, but the workers and the associations that are supporting those workers. So.
Thank you. And Haley.
Yes, I agree. I mean, I think a diverse set of voices in the room will always help to improve the actions and solutions that you land on. I also feel like sometimes we can get a little stymied by feeling overwhelmed by the challenges before us. And I think having a solid plan for what you are trying to achieve up front and getting all of the partners in the room to really commit to the goals will really help you as you move forward. So baby steps, just get started and begin tackling some of the challenges.
Fantastic. Well, I want to thank you three so very much. And for the participants who are on today, if you can hang on for us, because we have a survey at the end of this webinar, and we would greatly, greatly appreciate your feedback. And so with that, I want to thank our speakers. You all were fantastic. And I want to thank our participants as well as our funders, the John A. Hartford Foundation and the RRF Foundation for Aging. With that, thank you and have a great day.
Thank you. Bye all.
Bye, everyone.